major type of sensation. Now, of the special, well, I mentioned the special sensation that we'll cover, of course, within this segment of the course. Those are vision, hearing, taste, smell, and the balance. Okay, so those are the special sensation, and general sensation is we also call somatic sensation, and that within somatic sensation we divide the sensations into two groups. The groups that are initiated by the exteroceptors, which are the receptors that are located on the surface of the body, we call that exteroceptive sensation. And the case where the receptors are located inside the body, we call interoceptors, so interoceptive sensation. And we mentioned one thing that all sensation, they begin at the receptor, right? So at this all sensation, we talked about two concepts. One is sensation, which begin at the receptor, and the receptor carry the signal all the way. The signal initiated in the receptor is carried all the way to the to the the sensory area of the specific sensory area of the brain. Okay. Now, remember one thing, this is absolutely an important concept to understand that all sensation begin at the receptor. Now, for an example, if we say like I mentioned that our visual system is located on the back of our the brain, right? In the occipital lobe. I will talk about that later as well. So on the occipital lobe. Now, if you shine light on the occipital lobe of the brain, you will not see anything, right? Because the brain, the occipital lobe of the brain, that can interpret any visual sensation received received by the receptor. And what the receptor does is that it converts the signal into a language that our brain's sensory system can read. That's why if you touch the area of the brain which interpret the touch sensation or the pain sensation, if you apply painful stimulus on those areas, you will not feel pain because they cannot convert those different type of energy like a mechanical energy or a chemical energy into an action potential, and the only thing that they can receive is the action potential. So if you physically touch the sensory area or if you physically apply a painful stimulus and the sensory area of the brain, you will not feel pain because the brain is not, that area of the brain is not equipped with it cannot read that language. So for it to convert the signal into an appropriate language, for that to happen, you have to convert the signal to a language that can be read by or interpreted by the sensory system of the brain, right? So that's the reason we want to start the brain, right? So if you shine light in the front of our eyes, because eyes contain visual receptors, they can convert that electromagnetic energy into an action potential. When that travel all the way to the occipital lobe of the brain can interpret that one, right? But not that you shine light directly on the visual area of the brain cannot see it. So that is one thing. That is the importance of converting all sorts of energy or all sorts of stimulus into an action potential is absolutely important. That's where the receptor become important. Okay. And the other thing that we said is that most of the cases, the nerve ending, they serve as receptors, right? But not always the case. I will talk about those. And then at the end, you will see the nerve, the branch into several branches. Okay. Now, all those branches together, they form a sensory unit. The sensory unit is the all the peripheral branches of a sensory nerve. They form a unit. We call them sensory unit. Okay. Now let's get started with today's content. And now let me share the screen with you. Okay. Okay, desktop. If I share my desktop. Okay. So as I said, I will talk about the the receptors today. And in the last slide, during the last class, I mentioned that the process we call sensory transduction is the conversion of that different type of energy into an action potential in the nerve, right? So that is the thing. Now let's start talking about this. Is not important. So now look at the type of receptors. These are the type of receptors in somatosensory system. We said there are two different systems. One is the spatial sensation and somatic sensation, right? Now look at all the receptors of the somatic sensation or somatosensory receptors. They are all nerve endings, right? They are nerve ending, they are continuous with the next nerve, right? This is the dorsal root ganglia, and this is the nerve directly, right? So nerve ending is serving as a receptor, right? And also nerve ending have some modification. Here you can see there are some skin, and then here also some, it's showing some muscle spindle, but there could be some non-neuronal tissue. Oh, sorry. So there could be some non-neuronal tissue along with the nerve ending, right? So that is how the receptors work in the sensory system, right? Now, but this one is a little different. You see, if you look at the special sensation, this is not the nerve actually. This is a specific receptor cell. So the receptor cell for auditory system, we'll go into detail of auditory system. You don't have to worry about that at this point, but I want you to just understand the difference between the type of receptors. So in case of auditory system, this is something, it's a hair cells in the organ of Corti in the ear that serve as a receptor, right? Now this receptor is directly connected to the nerve. You see, this is the nerve, and the receptors synapse with the nerve. So whatever you see, whenever a auditory stimulus is received by the hair cells of the organ of Corti, that generates. So we say the receptor produce a generator potential, right? When this generator potential reached the threshold for excitation of this nerve, then it will produce an action potential here, right? But this is separated from this nerve. So this receptor is separated from this nerve. Now, a little bit different here. This is a visual receptor. We call this one, there are two types, rods and cones. So this one is more like a rod. Here, this one is different from this one. Here, you see the receptor here is not directly attached to the nerve itself. This is the ganglion cell axon, actually, that eventually form the optic nerve that carry the signal. Okay, now look at the interneuron in between. Okay, so see, there are three different things. One is the nerve itself is serving as a receptor, the nerve ending. Here, it's not the nerve ending, but the receptor cell or the structure, the receptor is synapsing directly with the nerve that will eventually carry the signal. And here, a little more different, that the nerve itself, the receptor itself is not even directly connected to this cell, to the cell or the nerve that will carry the impulse all the way to the brain. There is a interneuron located in the middle. So that's how different type of arrangement in receptors. Okay, now if we move, now what happened is that, so this is a neuron, right? Now I wonder whether you those who have a neuroscience background, for them it's very easy, very simple, but those who don't have a neuroscience background, no, it's actually good to have a quick review. The neurons have two parts. One is here in this neuron here, this is called the cell body of the neuron, and this is the process of the neuron, right? So cell body and process, these are the two components of neuron, and depending on the number of processes, neurons are divided into several groups. Now, if a neuron has only one process, we call it so that is the what is the term actually we use, unipolar. We call it a unipolar neuron. Okay, and if the neuron has two processes, we call it a bipolar neuron. If it look like one process, but one process is divided into two, that is, we don't classify it within bipolar. We don't also call it unipolar. We call it pseudo-unipolar. All the neurons in the spinal cord, dorsal root ganglia, they are pseudo-unipolar neurons. And then if you look at the motor neurons, they have a lot of processes. We call them multipolar neurons. Okay. Now on this one, this particular neuron, this type of neuron, we call them pseudo unipolar, because you see, this is the cell body. This is not the cell body of this neuron. This neuron is this part, and the cell body is here. This is another neuron here. Okay. Now, this is the cell body, right? So see, one process coming out from the neuron and divided into two processes. One goes towards the periphery, the one is going to the center. This one we call central process or central axon. This is the peripheral axon, okay? Now, so this one will be classified as pseudo unipolar, right? Now, if you have two processes, then one will be an axon, the other one will be a dendrite. Now, if you have multiple, axon is always one. If you have multiple processes, it will have one axon and multiple dendrites. Okay, so that is not the main focus of our class. Actually, I just wanted to go back and have a quick review of the basics. Now, this is the peripheral part of the neuron and the process, and this part serve as a receptor. Okay, again, we mentioned that receptors are the transducers that convert various forms of energy in the atmosphere into an action potential in the neuron. Okay, so that is the function of the receptor. Now, so this one is located in the skin, right? Now, when you apply stimulus here, the receptor will not produce an action potential. Receptor only will produce a localized potential. We call it receptor potential or generator potential. Okay, local potential or they don't propagate, they stay localized. Okay, they are non-propagated potential. So we call them generator potential or receptor potential. When this generator potential is big enough that it reaches the threshold of excitation of this neuron, then it produces an action potential. See, these are the action potential here. Okay, and remember, action potential are all or none law. They follow all or none law. Either they will make a full action potential, or they will generate a full action potential, full-fledged, or they will not respond at all. So now, whether they will respond or not, that depends on how big the generated potential is. So if the generated potential reaches the threshold for excitation of this one, then it will produce an action potential. And when it produces an action potential, it is a full action potential, and it will propagate all the way to the other end of this nerve. And you see, when the action potential reaches here at the end of the other at the junction of the other nerve, there is a gap here. So now the signal from here to transfer from one neuron to the other, the process that is involved here, we call it synaptic transmission or synaptic transmission, whatever we call it, and that is a chemical process again. This cannot be transmitted uninterrupted, actually, because if you have a synapse in the middle, so the signal need to cross that synapse. The way it does it is through a process called synaptic transmission. Okay, so that's the basic thing. Now, I wonder how familiar you are with the action potential, but action potential is not my focus. But I thought it's good to have a quick review of the action potential. So to understand action potential, you need to have an understanding of the normal potential difference between inside and outside of the cell. If you take a cell on its environment, right, and then you place an electrode inside the cell and place a reference electrode outside the cell, and then measure the voltage across the cell membrane, you will see the inside of the cell is negative compared to the outside of the cell. Okay, so that negative potential inside the cell, when the cell is not stimulated in the resting cell, we call it a resting membrane potential. Okay, so you see the resting membrane potential, it's a flat line, and you can see when we look at the current, how much is the resting membrane potential of this particular cell or neuron? It is minus 60. Okay, and it's always the case, resting membrane potential in all excitable cells are at rest, they are negative. Inside the cell is negative compared to outside. Now, how negative it is, it depends on how large the nerve fiber is, how small the fiber is, or how big the muscle fiber is, or how small the muscle fiber is, because any excitable tissue will have this potential difference across the cell membrane. Okay, so now at rest, the potential at rest when the cell is unstimulated or nerve is unstimulated, we call it resting membrane potential. Now, when you stimulate those excitable tissue, okay, now and then if they reaches the threshold for excitation, this is a very simple one. Generally, you need to from minus 60, you need to go to about minus 55 or minus 60. That is called the threshold for excitation. When you reach the threshold for excitation, you see a full-fledged action potential will take place. Now, when you have action potential, momentarily inside of the cell will become positive actually compared to outside, because when you do the stimulation, what happen in most of the cases, if the cell is excitable cell, that will the positive, the cation channels will open. In most cases, it is the sodium channel. Just let's keep it simple. So sodium channel will open. The sodium, if the sodium channel opens and sodium start going inside the cell, what will be the result? You see, you are inserting positive cell inside the cell, right? If you do that, what will happen? The positivity will build up inside the cell, and eventually minus 60 will start going to the positive direction, right? Minus 60 to minus 50 is already 10 millivolt positive, right? And if you can go from minus 60 to 0, that is already 60 millivolt positive. So in some cases, 50 millivolt positive is a bit exaggerated. Most of the cells, it goes to the positive direction of say like 10 or 15, something like that. Some cells actually even stop at 0. But 0, remember, 0 is, in this case, 0 is 60 millivolt positive, right? It was originally at rest, it was minus 60. Now, if you can move it to 60 as 0, it's already 60 millivolt positive. Anyway, how the cell lose its polarity? Because of the entrance of sodium ion. Why? Because in response to stimulus, the sodium channels are open. Now sodium is going in, carrying positive charge with it. So it reverts the polarity of the cell. Okay. Now this happened. This phase is called depolarization. You see, this phase is called, we call it depolarization. And how it happens? It is caused by the influx of sodium. Now, very quickly, within few milliseconds, the sodium channels will be closed because these channels are voltage dependent. I don't want to get into this, patch clamp things at this point, but these channels are voltage dependent. So at the voltage sodium channel open, when it goes towards the positive, sodium channels will be quickly closed. Not only sodium channel will close, the potassium channels will open. Now, the direction of flow of potassium is outwards. Direction of movement of sodium is always inwards. Okay, so when the potassium channel open, what will happen? Potassium will be moving out of the cell. Now, what will be the result if the potassium start moving out of the cell? Cell will start losing its positivity, right? So you see, from minus 60, it became plus 50. Now, when the efflux of potassium starts, the cell will start losing its positivity, and it will eventually reach its resting membrane potential. It will come back to minus 60. But even at its resting membrane potential, before the potassium channel are closed, cell goes in fact more negative than its resting potential for a transient period of time. That we call hyperpolarization, because cell is already polarized, right? Minus 60 is a polarized cell. Now, when you make the cell from minus 60 to minus 70, this is not the resting status. Resting status was minus 60. So this additional negativity, additional polarity on the top of its resting membrane potential, this extra negativity, we call it hyperpolarization. Okay, so remember this in three important phases. One is depolarization caused by sodium influx. One is a repolarization, it comes back to its polarized state, is by potassium efflux. And even after reaching the resting membrane potential, it goes further down towards negative, more negative than its resting membrane potential. We call that status, we call it hyperpolarization. So anyway, so this is not my purpose is to talk about the action potential or resting membrane potential, but as we are talking about action potential all the time, I thought it's important to have a quick review of the action potential. Do you have any questions so far? Because it's a very strange actually feeling that we don't we are not seeing each other in a in-person setting. So I just want to make sure that you are not lost actually. So that's why last year when suddenly everything changed, we were not even familiar. I didn't even hear the name Zoom. So we had no idea what Zoom is. So what we did, we find out ways to record lectures and send them to students. We tried a PowerPoint with audio narration. We tried PowerPoint with the video, some voice over on that. And then finally, we figured out, so far we may even change that live events are better actually for the students. So, but what I'm doing, I'm recording these lectures actually. So at any point, if you want, I can send those recording to you as well. And I requested other faculty in this course to use the same Zoom link so that I can record their events as well. And in case if you want to have a review of what we said, we can send you the audio, those audio files as well. Okay, if you don't have any question, let me move forward. So look at this one. This is, again, we said the generator potential are also called a receptor potential, right? Now, this is a receptor, it's a nerve ending here, right? And see, I said there can be some non-neuronal tissue. So you see there are some non-neuronal tissue surrounding the nerve, but the actual receptor is this one, but nerve ending, right? But we call the whole thing, we call a receptor, right? We call it a Pacinian corpuscle. Okay, I will talk about Pacinian corpuscle later on as well. So if you apply a stimulus on a Pacinian corpuscle, initially, if the stimulus intensity is small, it will create a potential like this. Yes, but the nerve that is attached to this one has a resting membrane, the threshold for excitation here. So unless this generated potential reaches this level, there will be no action potential generated. So if you just stop in this one, you see there will be just a generator potential, no action potential will be formed. Okay. Now, if you increase the intensity of the stimulus, now you create a generator potential which is little bigger, but still it is not good enough to produce an action potential because it's still below it. We call it sub-threshold stimulus. Okay, it didn't reach this threshold yet. But if you increase the intensity even more, now your generator potential reach here, which is at the level of threshold for this neuron, okay? So what will happen when you reach the threshold for excitation? You see a full-fledged action potential. So as I said, if you try here, there'll be no action potential. At the end of this one, no action potential. At the end of here, a full action potential. So as I said, action potential is always a all or none. It follows the all or none theory. Either there will be full-fledged action potential or there will be nothing. Okay. So again, this phase is depolarization caused by influx of sodium. This phase is a repolarization, which means cell is getting back to its polarized state. And this phase, which is below its resting membrane potential, this phase is the hyperpolarized state, right? Okay, so this is, I think we talked about this one as before as well. So this is simple concept. Now, look at this one. These are all touch receptors. Okay, touch receptors located in the skin. Three of them. There are four examples here. We call it Meissner's corpuscle, the Merkel cell, the Pacinian corpuscle, the Raffinis ending. These are all mechanical receptors present in the skin. Now, one important thing, very important concept that you have to understand, that the somatosensory system, okay, they encode, you see, as I mentioned here, encode 4 attributes of stimulus. Okay, these are 4 primary attributes of a stimulus. So what are those attributes? Number 1 is the modality. Now, modality of the sensation is, I wonder how to explain it to you. So the modality of sensation is type of stimulus, like pain is a modality, touch is a modality, the visual stimulus is a modality, the sound is a modality of sensation. Okay, so there are different modalities of sensation. Like if we talk in the layman's term, those who have no idea about neuroscience, right? They also know that there are five senses. Have you heard that thing, the five senses? Those five senses include touch, the vision, the hearing, the smell, and taste. These are the five modalities of sensation that if we talk in the layman's term, those will be five sensation. But when you study neuroscience, we cannot use that very simplified classification, right? So we want to make the classification a little detailed. Those five sensation, you know why even the lay people, they know about these five sensation? Because all these five sensation, they reaches your level of consciousness. Okay, so let me explain it to you. So if I touch my hand here, my palm of the hand here, okay, I can feel it, right? Even without seeing it, I can feel it because it reaches my conscious level. If you apply a visual stimulus to my eye, I can see it because it reached my level of consciousness. Okay. If you put something of any taste on your tongue, you can feel the taste because it reaches your sense of your level of consciousness. But so general people understand those, right? That's why they call five senses. But there are sensory inputs that are continuously going to the brain, but that never reaches our level of consciousness. For an example, a very typical example will be, you see, if you see a muscle of a normal individual, you see, we can have the muscle either contracted or the muscle is relaxed, right? Contracted muscle or relaxed muscle. These are the two main status of a muscle, right? These are very obvious because they reaches our consciousness. Either my muscle is relaxed or my muscle is contracted. I know that. But you see, so these are actually not the two status of a muscle. There is a third status as well. If you see the neurologist checking a patient, there are some people who have paralyzed, right? So those who have paralyzed, their nerve is damaged to a particular muscle. That muscle is not a relaxed muscle actually. We call that muscle is a flaccid muscle. The muscle doesn't have any resistance. So even my muscle, which doesn't have in which is not contracted, still it has a basic tone. We call it a muscle tone. Muscle tone is a very important concept. So our muscles are not flaccid actually. Even when we are not contracting the muscle, they are not flaccid. They are in a state between flaccidity and contractility. That is called the muscle tone. So muscles are normally in a state of partial contraction. They are partially contracted. That's why we don't consider them as flaccid muscle. Those people who lost their muscle tone because their muscle lost its nerve supply, denervated muscle, they will be flaccid. They doesn't have any resistance actually. If you stretch, they doesn't resist because they are flaccid muscle. Now, if I contract the muscle, it is a contracted muscle. Now, in between contracted and flaccid, there is a state of partial contraction of the muscle we call muscle tone. So now, all muscle is maintaining, all our skeletal muscle, they are maintaining a muscle tone, right? But are you aware of the fact that your muscle are in a state of partially contracted state? No, because it doesn't reach the level of our consciousness. But that is a very important modality as well, right? But it is not included in the five senses. So in addition to five senses or five modalities, there are much more actually that we will be dealing with. Okay, we will be dealing with in neuroscience. So just to remind you that those are not only the five senses, there are other modalities of sensation. Why the general people doesn't care about them? Because they don't feel it, because those sensation never reaches the level of consciousness. That's why the lay people, general people, they will ignore it. Okay, so number one is the modality of sensation, right? Now number two is the location. That also we call, also describe it as a receptive field. Okay, now if you look at these two, you see the Meissner's corpuscle and Merkel's disc, they have a very specific area of the location, the stimulus that is coming from, right? And look at this one, the Pacinian corpuscle and Raffine is ending. So where you can pinpoint your stimulus, you can pinpoint on this one and this one. This will be very specific, but this one, you see, no specific area. You are feeling something in this area, but you don't, but the receptive field is big, large, but it is not very well localized. On this one, yes, intensity is higher here, but there is a low intensity area around it. Okay. Now, if you have a high intensity, if you have good nerve supply in those areas, they can eliminate this surrounding as a noise. You see, they can eliminate noise, so they can pick up this area. But that is not the quality of this receptor. That quality you will see in this receptor, right? So you see, there is no noise actually around it, right? Very specific this area, small receptive field, you can pinpoint. If you touch, say like if you touch the tip of the finger, because they contain a lot of sensory nerves. So if you touch the tip of the finger, you exactly know, even without seeing, where you have, where a pin touches your tip of your finger. But if you do it on the skin of your back, that is not as sensitive as the skin of the tip of the finger. Okay, which means the receptive field is big. So when you touch a pin on the skin of your back, you know that somewhere around an area this big, there is a pin touched your back. But if you do it on the tip of your finger, because you have so many nerve fibers, you can localize it very specifically, that okay, on the tip of my index finger, not on the side, not on the left, not on the right, right in the center, there is something touching. So we can be very, very specific. So this type of receptive field will give you a very well localized response. See, if you look at, like, somatic sensations are generally very, very specific, well localized. But when the sensation come from our viscera, from internal organ, they are very poorly localized. That is a different issue. We will talk about it later. But you see, you cannot tell people that if you come to the doctor and say, my stomach hurts. But do you go to doctor and you say, my hand somewhere? You don't say it. You see, the tip of my index finger is a problem. There is a cut on the tip of the finger. But when you go to doctor, you say, my stomach hurts. But stomach is this big area. I say, which part of the stomach hurts? You say, I have no idea. Because of the receptive field is so big, any information that is coming, you will feel that it is coming from your stomach. And for the lay people, when they say my stomach hurts, they mean abdomen. The whole abdomen is hurting. So that depends on how well localized your signal is, right? That depends on what type of nerve is carrying it and how well the area is innervated, okay? And then intensity and time course, they are other two very important, the attributes of a stimuli. Now look at the stimulus here. The same stimulus is applied, same intensity, same duration, right? Same intensity, same duration, same intensity, same duration, same as this one. You apply a stimulus of same intensity, same duration in all these four receptors, but look at how they are responding. This one produce some quick response, and then no response at all. This one initially quick, slowed down a little bit, but it's still continuous. As long as the stimulus is there, you have signal going through, right? Action potential are produced. On this one, very quick burst, and then nothing after that. But this one is similar to this one. So this one and this one are a bit similar, right? In their intensity and in their time course, which means these receptors are, as long as you have a stimulus applied, they don't get adaptation, okay? They do not become desensitized. So as long as you have stimulus applied, they will keep responding. But on this one and this one, so they are similar, right? These two, what happened in these two cases? They produce signal initially when you stimulate, and then they quickly adapt. After that, they will not send any signal, as if there is no stimulus there. But in fact, the stimulus is still there, but you don't feel it because no signal is transmitted. Okay, so do you see the difference between this one and this one, and this one and this one? So this one and this one are similar, which means they are they don't have adaptation. The one of the criteria of the receptor is they become the adaptation is, yesterday I was talking about the glasses. As I said, if you initially at the beginning, if you take it, even if you change your frame, so from the plastic frame, if you change it to a steel frame, you will feel something is sitting on your nose. But after a few days, you don't even know that you are wearing glasses, right? Because the pressure sense that is transmitted from the pressure that is applied by your frame on your nose, initially it produced a lot of signal. So you are always aware that something is sitting on my nose. But over a period of time, stimulus is still there, but you don't feel it anymore because of the adaptation of the receptors. Again, there are four the attributes of a stimuli that is encoded by the receptors. They are modality, their location, their intensity, and their time course. Very important concept. Now, as I said, so here, so see, this is an area. So this pencil is showing the area. This is the skin, right? Surface of the skin. Now, if you apply a stimulus with this one, you press on the skin, so the area, the receptors of this area of the skin will be activated, right? This area of the skin. Now, again, like the previous one, if you cannot, so the whole area, the receptors of whole area will be stimulated, so you cannot pinpoint that this was the area where the main stimulus was applied. So the receptors have a special capacity to eliminate noise. You see, how do they eliminate noise? What do they do? Only the receptor of this area will produce excitation, and the receptors in this area and this area, even though they were excited, but they were inhibited from producing a signal. Only this area will produce a signal. So that will, we call it noise reduction. So you see, that is called lateral inhibition, because these are on the lateral side, right? So the lateral areas from the center of the stimulus, those areas are subtracted actually from the excitation. So these areas are inhibited, this area is inhibited, only this area is producing an action potential. This very special, the function of the receptor, it's called lateral inhibition. Okay, so that this is a way you can eliminate noise so that you pick up your signal from the area of excitation. Okay, rather than is a large area, you don't know actually where the stimulus is. Now, this one is the relation between the as you increase the intensity of the stimulus, we say the frequency in the nerve action potential, unless it is adapted, it goes up. So the impulse frequency, the frequency of action potential depends on the intensity of the stimulus. Okay, now look at this one. So this is surface of the skin, right? Surface of the skin. Now you are applying pressure on the skin with a glass probe. So here is your probe, right? That is your stimulus. What type of stimulus it is? It's a mechanical stimulus, right? Because you are pressing the skin with a glass probe. Now what happened here? You just touch the screen with the probe, which means it is a touch. So the touch receptor will be stimulated, but pressure receptors will not even respond, right? So now, as you touched it, we are talking about the pressure receptors here. The action potential in the nerve attached to the pressure receptor, they don't produce any signal, which means they just ignore this stimulus altogether. They feel they are not even excited because you just touched the probe. But if you look at the intensity, if we measure it to about 55 millimeter of mercury, but the pressure receptor even didn't respond, it just ignored it, right? Now when you increase so this was the intensity, right? This one, say like about 55 millimeter of mercury. Now, if you increase the pressure to about 60 millimeter of mercury here, then look at this. This is the nerve, and it divides into four. This is the sensory unit, right? Four terminal branches. Now, when the signal intensity goes up to about 60 millimeter of mercury, this is an hypothetical scenario. I'm just showing you how the increased intensity will increase in the more bursting of the nerve fiber. Now, when it goes up to 60, you see out of four, the one which is nearest, that one was excited, and then it produced some action potential in this nerve. Okay. Now, if you keep increasing, if you increase the signal intensity to about 100 millimeter of mercury, now you see the glass probe is pressing little more harder. Now, instead of one here, two branches now are producing action potential. Now you look at, see the frequency of action potential is going up. Now, if you go up further to about 130 millimeter of mercury, then you see, look at the indentation of the skin, and then three of the fibers out of four are sending signal. So frequency of action potential is even more. Now, if you go up to 180 millimeter of mercury, you see more indentation of the skin, and all four now the peripheral processes will be now excited. Look at the nerve, the whole nerve is now excited, and look at the frequency of action potential. Okay, so which means the more is the stimulus intensity up to a certain limit. Of course, there is always limit. We have to be careful, because there is, so if you reach this one, if the pressure, if you keep applying more pressure, at some point the pressure receptor will not even send any response, because at that point the pressure can become a painful stimulus. Now completely different type of receptor will respond, because that is now it becoming painful. So it will not be pressure receptor anymore. When it becomes painful, another subset of receptors called nociceptors or pain receptors, they will now start to fire. Okay, or if you have a sustained stimulus of here you see we increase the strength 60, 55 to 65 to 100 to 130 to 180. We keep changing the stimulus, but you see, if you maintain a stimulus, if you keep a stimulus of same intensity, that is where the term adaptation comes. Okay, now let me go back to this one. Look at this one. This is a sustained stimulus of the same intensity. That's why you see the adaptation here. But if you go from here to here to here to here, they will not be adapted, right? So you have to remember, adaptation takes place when you have a prolonged stimulus of a same intensity. As again, if you take the example of the glass, okay, so this is the glass of the frame is the same weight, and it's there for a long time, so that the receptor get adapted. But in this case, you are changing the intensity. As you keep changing the intensity, the frequency of action potential will go up. Did you get this concept? Did you get this thing? Is it okay with you? Good. Now, if we move further, so as I said, so when this signal is carried, so receptors are bringing signals, right? And they are coming to the dorsal root ganglia. Do you remember we showed the dorsal root ganglia where all the signal will come, because it is the cell body, and from cell body it will travel to the spinal cord, right? Now, when the signal, because this neuron, this nerve, as it is carrying signal, it will carry signal from pain receptor, touch receptor, pressure receptor, all sorts of receptors are there, right? So the nerve will carry all type of signal. Now, when they come here to the cell body, it depends on which particular cell body it is stimulating. That will determine the output of your signal, right? Now, this is a somatosensory ganglia, or it's a dorsal root ganglia. It contains many different type of neuron. Okay, see, there are many different type of neuron. So now if you stimulate this one or this one or this one, stimulus will be like this one, this one, this one. Okay, so these are mechanoreceptors. When you stimulate them, look at the response, look at the output of the response. Here there are a lot of responses initially, and then it disappears, right? Here, there are some initial response and it disappear. But this one is continuously sending signal, right? So do you see the difference between this one, and this one? So this one is the hair cells, and this one is also rapidly acting. So this one and this one, they get used. This one, initially it get used at the beginning. So here is the stimulus. See, stimulus, and then stimulus go down. At the beginning of stimulus, it will fire a little bit, and then at the end of stimulus, it will fire again, but in between, it get used to it. But here again, it produced some response at the beginning, some response at the end. In the middle, it is because it got used to it. It's adaptation. It's quickly. It's this type of receptor we call rapidly adapting receptors. And this is also, more or less adaptation takes place in this one. But this one is called SA, indicate slowly adapting receptors. This receptor doesn't get adapted. So, but there is some adaptation. If you look at the beginning, look at the amplitude and the frequency of action potential, is a lot of them, right? But then it slowed down a little bit. So which means there is some adaptation, but they are very slowly adapting. That's why this group we call rapidly adapting receptors. This one we call slowly adapting receptors. Okay. Now, on the same dorsal root ganglia, if we stimulate these neurons, so like this one, this one, this one, they are different. The different type of neurons are there in the ganglia. Now look at this one. These are pain receptors. These are the mechano heat receptors. See, no adaptation there. Look at this one. There is some adaptation. Look at this one. There is no adaptation again at all. So which means, what does it mean? That means there are different type of neuronal cell body in the dorsal root ganglia, and depending on what type of signal is coming to them, they will respond accordingly. It's not that there is one dorsal root ganglia for this type, one dorsal root ganglia for that type, which means there will be a lot of dorsal root ganglias there, right? And another term, actually, let me clarify one term. When we say ganglia, when we say ganglia, we mean these are the collection of cell body. Again, there are two parts, right? Cell body and cell processes. So when we say nerve fiber, which we mean an axon or cell process. When we say ganglia, we mean the collection of cell bodies. But this, when the collection of cell bodies is outside the central nervous system, we call them ganglia. The similar collection of cell body within the central nervous system, we call it nucleus. You will hear we use those two terms almost synonymously, interchangeably, but they are different, actually, a little different, but functionally they are same. They are collection of cell body. When the collection of cell body is outside the central, so what are the components of central nervous system? They are brain and spinal cord, right? So if you have collection of cell body within the brain and spinal cord, that collection of cell body, we will call it nucleus. Okay, like we say nucleus of vagus nerve or nucleus in the spinal cord. So these are collection of cell body within the central nervous system. Same collection of cell body when it occurs outside the central nervous system, like on this one, a dorsal ganglia. Dorsal ganglia is not within the central nervous system. We call this ganglia. So remember the difference between the ganglia and nucleus. They are functionally they are same. They are collection of cell body. Okay, but their location is different. One is outside the central nervous system, ganglia. One is inside the central nervous system, we call nucleus. Okay. Now, so different, as I said, mentioned before, that the receptors, they respond to a very specific energy. That law is called the law of specific energy. Okay. Last one, do you remember I mentioned that it's a pressure receptor, right? So when you push with the glass probe, the pressure receptors were stimulated. But when that reaches at a level when it's becoming painful, a very different receptor will now be stimulated, which means the pressure receptor cannot transmit the pain signal. Pain receptor cannot transmit the pressure signal. Touch receptor can only transmit touch sensation. They cannot transmit a pain sensation. For an example, let's see, if you touch your tip of the finger with a pin, right? Initially, it will not be painful, right? You just touch it. So you think, even without seeing, something looks like sharp is touching you tip of the finger. So what type of receptor will be stimulated? It will be a touch receptor. That will be stimulated and the signal will go to your brain. It may reach your consciousness, most likely, because if you touch, if you feel it, which means it reaches your level of consciousness. But now, if the sharp pin, if you start pressing on the sharp pin on your skin, now it is not a touch sensation anymore, it is a pain sensation. Even though your pin is exactly in the same spot, instead of touching, now you are pressing, which is producing pain. Now a different subset of receptor is stimulated, even though your pin was exactly in the same place, because same strip of skin have both type of receptor. It has pressure receptor, it has thermal receptor, it has pain receptor, it has touch receptor, everything. Okay, so that is called the law of specific energy, or it's also called labeled line principle. Okay, so that is a very specific way a receptor normally respond. Okay, now see, again, also, if you put something warm here, see, so if you dip your finger in a warm water, you don't feel any pain, right? It even in the cold winter, it feels good. So you feel some warm temperature on your fingertip. So you feel good. You see, oh, there is this water is warm. Okay, that's all. Your sensation is warm, warmth. But if it is a boiling water and if you dip your finger there, that will not be a thermal sensation. That will be a pain sensation. So again, a very different subset of receptors will be stimulated at this point. Did you get it? So this is called the level line principle. So just to explain it with this diagram. So this is a strip of the skin, right? And you are touching here or here or here. Okay, so the two neurons are carrying this touch sensation. One is this one. You see dorsal root ganglia. This is the peripheral process. It divides into three branches, right? So now if you touch here, so if you touch and if the touch is strong enough, if the touch is weak, only this one will carry signal, right? If the touch is stronger, then this one, and this one will be stimulated, but it cannot stimulate this one. This is a completely different nerve, right? Right? So depending on the touch, either only this part or all these three can be stimulated by touching at point 3, right? 3. Okay. Now, by touching at 1, you can stimulate either this small one or this 1, 2, 3. You cannot stimulate this one because this is a completely separate nerve, right? So this 1, 2, 3 can be stimulated by touching at the point 1. But if you touch at 2, which means you are touching on this one and this one, now both this nerve and this nerve, both of them will be stimulated, will carry the same response. So which one will be more, which one you will feel better, 3, 1 or 2? You will be able to much more clearly feel the touch at the point 2, right? Because that will be carried by 2 nerves now. So that signal intensity will be good, and then you will feel it more precisely at a point where it is touched, because 2 nerves are now involved and they are carrying this sensation. But in this case, it's just 1 nerve, this one. In this case, this is 1 nerve, this one. But when you touch here, you are stimulating both nerves here now. So that make your stimulus much more precise. Okay, now on the same area, so on the same strip of skin, if you apply a painful stimulus with either A or B, look at, see something like sharp. If you apply a painful stimulus on this one, even though it is within the region, the same region of these 2 nerves as well, right? Those are, we say, touch receptors. But now when you are applying painful stimulus, instead of stimulating these 2 nerve, now this nerve is stimulated. Look at it, it's the same place. But depending, that is what we say level line principle, or not, and the principle of specific energy. What type of stimulus it is? It is a painful stimulus. So you have a specific nerve to carry those painful stimulus. If it is a touch stimulus, there are specific nerves to carry the touch sensation. This one will not carry touch sensation. These two will not carry pain sensation. They are very specific for a specific form of energy. Okay, did you get it? Good. Now, so we are talking about the neuron all the time. Let's talk. This is not a part of this class, but I just wanted to have a general idea about, in addition to the neurons, there are some supporting cells, a lot of supporting cells in the nervous system, right? They are called the glial cells. Glial cells are not neurons. Neurons are the main structural and functional unit of the nervous system is neuron, right? There is no doubt about it. But you cannot have a nervous system built of completely neurons. There are a lot of supporting cells. Now, three of them we need to be we need to know for sure. One of them we call astrocytes. There are a lot of astrocytes in the central nervous system, okay? And then the other one is the oligodendrocytes. Now, forget about astrocytes. We will not talk much about astrocytes. But for us, it is important for understanding our concept that we are trying to explain. Oligodendrocyte is a type of glial cell. They are supporting cell. Remember, they are not neurons. They are located in central nervous system. They are a type of glial cell, but they perform a very specific function. What they do, they wrap around the axons or the nerve fibers and insulate them. That is very important, insulation. The more insulated a nerve fiber is, the more thick will be its diameter, and faster will be the signal transmitted through that nerve. So the smaller diameter the nerve is, the slower will be its speed of conduction through that nerve. Okay. Now, how the more or less, you see, the neuron fibers are almost, they are most of the time they are very similar. How the diameter then varies? Diameter varies depending on how much myelinated the nerve is. This process is called myelination. You see, these oligodendrocytes, they, with their processes, they wrap around the axons and insulate them. We call them myelination of the nerve. All the nerves in the central nervous system are myelinated by one type of glial cell. We call it oligodendrocytes. Okay. Now, why myelination is important? We said one thing that you have to remember, that myelination will, the more myelinated a fiber is, more will be its diameter, and faster will be the transmission of signal through that nerve. Now, so this is the peripheral nerve in the peripheral nervous system. This also have a myelination, but in this case, myelination is done by another type of, the glial cell. We call them Schwann cells. The Schwann cell will myelinate the nerve of the peripheral nervous system, and oligodendrocytes will myelinate a nerve in the central nervous system. Okay, so now look at how the Schwann cell look like. This is a Schwann cell, this is an oligodendrocyte, and this is an astrocyte. This is a microglia. Any of you do any microscopy or just fluorescent microscopy of the neuroglial cells or the neurons? Any of you? Do you have any experience of doing it? It's very nice, actually. This is a fluorescent microscope image. If you see under the fluorescent microscope, they look wonderful. They look wonderful. If you just stain them with, there are a lot of stain. You can do FITSI, you can do TRITSI, you can do, some other stains. But when they are properly stained, if you look under the fluorescent microscope, they look gorgeous. See, this is an astrocyte. I used to when I used to work on the rabbit retina, we used to inject lucifer yellow on these astrocytes, and then they immediately light up. They look wonderful under the microscope. Anyway, so this is an oligodendrocyte. Most important, what oligodendrocyte does, it is a glial cell, and it does myelination of the central nervous system. Okay, And these are Schwann cell, another glial cell that will produce myelination of the peripheral nervous system. And this one is astrocyte. We don't worry about much about astrocyte at this point. Okay, so these are the three type of glial cell: astrocytes, oligodendrocytes, and Schwann cell. Schwann cell is important for myelination in peripheral nerves. Oligodendrocyte will do the myelination of the nerves of the central nervous system. But for our purpose at this point, all I want you to remember is the more myelinated a nerve is, more will be its diameter, and faster will be the speed of transmission of signal. Okay. Now let's come to this one. So this is a classification of nerves, the myelinated nerve versus unmyelinated. Okay, look at the diameter here in microns, 20 micron, 15 micron. Now unmyelinated highest is 22 microns, right? So these are the increased diameter because of myelination, and these are unmyelinated, right? Now look at the conduction velocity. This one is 120 meter per second, whereas this one is 2 meters per second. This is the highest of the unmyelinated, right? And this is the highest of the myelinated, 120 meters per second versus just 2 meter per second. You can imagine how big the difference, and all this difference is caused by myelination, and myelination is done by oligodendrocytes in the central nervous system, Schwann cells in the peripheral nervous system. That's why even though they are not neurons, don't ignore them, okay? Don't ignore them at all, because they do a very important function. Now, as a general classification, you will see at times, sometime we call type A fiber. Sometime we will say type B fiber. You see, or see type A fiber is again divided into A alpha, A beta, A gamma, A delta, depending on their diameter, right? The A fibers are the A fibers are the myelinated fibers. They are subdivided into alpha, beta, gamma, and delta. We say A alpha, A beta, A gamma, A delta. They are all A fibers. Depending on the diameter, they are divided into 4 groups. And unmyelinated fibers are called C fibers. There is no subcategory within those, just C fibers. When we say C fibers, we know that these are unmyelinated fibers. Okay. In fact, the unmyelinated term itself, is strictly speaking, is not right, because even the unmyelinated fibers, they have a small covering on their top, but that is not very significant. It's so insignificant that we consider them unmyelinated. Okay, but there are no naked nerve fibers; they all have a covering. Okay, now in the sensory system classification, you will see sometimes we say type 1 fiber, type 2 fiber, type 3 fiber. 1 is the highest diameter, the middle diameter, and then type 3 will be the lowest diameter. Now, depending on, so now you can look at this. I don't need to read this one. You see which type of, the receptors will have what type of fibers, how they are carried. All you need to know, you don't have to memorize this chart. All I want you to remember is that myelinated fibers, because of the myelination, they are more insulated. The speed of transmission of signal will be faster, and more the myelination, more is the diameter, faster is the speed. That's all you need to remember. And C fibers are unmyelinated fibers. Unmyelinated fibers will have less speed in the transmission of signal. Okay, and this one you may have to remember A fibers and C fibers. Within A we have A alpha, A beta, A gamma, A delta. You don't have to remember A alpha is between 20 to 10. You don't have to, you don't have to memorize that. Just remember that A alpha is the highest diameter, A beta is in the second, A delta is third, A delta is the minimum diameter, actually smallest diameter within the myelinated nerve fibers. Now, pain is an important sensation, actually, and no matter how much we hate pain, pain is actually protective for us. In most of the cases, pain is a good thing. Actually, it's a very good protective thing. For an example, now if somebody has a blood vessel in his heart or her heart blocked, what will happen? There will be no blood flown into the part which is supplied normally by that vessel, right? What will happen? That situation, we call it heart attack, because that part of the myocardium or the heart will not get any blood supply. So the cell will start dying, and that will produce pain. Now, because you feel pain in the heart, that will take you to the ER. You rush to the ER to get treated, right? Now, if there is no pain sensation, your heart will be dead before you even know it, actually. And then we will all die at home even before ending up in the ER, actually, for treatment. So remember, pain is, even though it's unpleasant sensory signal, but this is, in most of the cases, it is protective. It gives us an indication that something wrong is going in, so that we can take appropriate measures. Okay. Now, pain is generally, there are two types of pain. One is the sharp pain, or we call it first pain. That is okay. Now, look at the pain signal is carried by. So that's why it's one good thing is that pain is not carried very quickly, because A delta fiber is the smallest of the myelinated fiber, right? And C fiber is the unmyelinated. So the first pain is transmitted by A delta fiber, and second pain, the slower phase of this pain, this is more agonizing pain, actually, because after an inflammation or after a process, the pain continues for a long time. That is the slow, we call it second pain or slow agonizing pain. And that is carried by even, smaller nerve fibers, which takes signals very slowly. But first pain is carried by 8 delta fibers, which is smallest in terms of diameter within the myelinated nerves. Now, there are a few things related to pain that I want to bring to your attention. Uh, like when there are two terms that you need to be familiar with. One, we say hyperalgesia. Hyperalgesia is something when you have an exaggerated response to a pain stimulus. Okay. So normally, you see, different people respond to pain differently, but this is not that case. This is an exaggerated response to a painful stimulus. Okay. Now look at so this is, you see, this is a sharp, the painful stimulus on the skin, right? So in response to the stimulus, you see, this is a pain fiber. This is supposed to be stimulated and carry the pain signal to the spinal cord, right? And eventually it goes to the brain and we feel pain. This process is complicated by when a painful stimulus is applied on your skin. See, there are some other things happen. So there are some substance released in response to this painful stimulus here. See, there are some from the damaged skin. There are certain things released. One is called bradykinin. One is 5-hydroxytryptamine, 5-HT, and prostaglandin. So, and then also the substance P and CGRP. CGRP is calcitonin gene-related product. You don't have to memorize it. So this and substance P, this released, and in response to that, the mast cell, they secrete histamine. Also, they causes dilatation of the blood vessel. Now, all these things together, and then these three things specifically and including histamine, bradykinin, 5-HT, and prostaglandin, they increase the sensitivity of the pain receptors. So if you don't have any of these things released, this pain stimulus will be one type. But if you pre-sensitized your pain receptors, now the small stimulus will produce a bigger response, right? And that response, then exaggerated response to a painful stimulus, is a term called hyperalgesia. Okay, hyperalgesia is an exaggerated response to a painful stimulus. Now, allodynia is different. Allodynia is when a normally non-painful stimulus will produce pain. Okay, so a clear example, let's take a daily life example. So normally, if you take shower in a warm water, say normally you have the temperature of water at a certain degree, right? So like say like 30 degrees, 35 degrees or something, 37 degrees is the warm water that you take. Normally you take shower in 37-degree warm water, right? You don't feel pain, you feel good. It's very comfortable for you. This comfortable temperature. But say like you went to a sea beach and you have a substantial sunburn. So if you have sunburn on your skin, the same temperature that you used yesterday, today, the same temperature is giving you painful stimulus. Normally, 37-degree was not a painful stimulus for you. You are used to it. You take shower at the temperature using a certain degrees. But exactly the same temperature tomorrow or today is causing pain. So that temperature is not a problem here. The problem here is that you had problem in your skin because you went to the sea beach, you had a exposure to sun, and you have sunburn. Your skin is already hypersensitized. So normally the stimulus which is normally painless, now today it is giving you a painful stimulus. So that is called allodynia. Allodynia is non noxious stimulus if it produces pain because of some secondary reason, okay? And hyperalgesia is a normal, it's a noxious stimulus for sure. It's a painful stimulus, but it is giving you an exaggerated response because of the other components. It's not because of this one. This one will produce a pain. So like, you see, when you go to doctor's chamber, they say, tell me where is your pain, 1 to 10. So if this is the one thing, and in absence of these, you would have said, yes, it is a painful stimulus. How much? You say like 5 or 3, depending on individual, it varies. But these 3, along with these, now doctor asks you like 1 to 10, where is your pain? You say 10. So now this was actually not 10. This was responsible for 3. The remaining 7 is caused by these additional factors. So this stimulus of 3 is giving a pain equivalent to 10. That is called hyperalgesia. Okay. Now, normally you take a shower at a temperature which is not a painful stimulus. Now, because of a problem in your skin, you are feeling pain today. That is allodynia. Okay. Any question on this? Good. Now, I mentioned briefly about the referred pain. You see the mechanism of referred pain. Let me quickly go over the referred pain. You see, this is a heart muscle, right? Now, if normally we don't have no signal, no pain signal transmit through this one normally, okay? Because we don't feel pain in the heart, right? Because this nerve doesn't carry any sensation normally. But you see, this area of our body, always you feel some touch, some pain, some temperature, something. Always sensory signal is transmitted from this area. This is very common. But at the age of 60, if someone has a heart attack, so heart attack, that sensory signal will be carried by this nerve, right? Now, normally, this segment, this spinal nerve, normally it carries pain from this area. But today, after 60 years, suddenly a pain is coming from here. Now, you see, look at this one. They end up in the same place. Eventually, they end up in the same place in the brain. So how will brain know that where is the pain coming from? Brain think as usual, it is coming from this area. You feel pain here. You go to doctor, you say, I'm feeling pain here. Actually, you have nothing wrong in this area. The problem is coming from your heart. So this is a type of brain get confused with the source of pain. Brain think it's coming from here, so you feel pain here. Eventually, when the pain becomes very severe, then you eventually realize that it is coming from your heart. Okay, eventually you will know that, but initially brain get confused. Brain cannot distinguish where the pain is coming from, because this nerve always carried pain from this area, never from this area. It's always coming from this area. So when it goes to the brain quickly interpret it as a pain coming from here. But if, I hope none of us will have that experience. If anybody have that experience, that will come from the heart, and brain initially will fail to interpret it properly. That failure of interpretation of brain initially, that pain from here, source is here, we are feeling here, that type of pain is called a referred pain. Okay. Now, I mentioned muscle spindle at the beginning, right? So muscle spindle is the receptor located within the muscle. So if you think that this is the whole muscle, right? And this part of this is the receptor portion of the muscle. Every muscle, every skeletal muscle, inside them, they have receptors. The receptors located inside the muscle is because of their specific, shape. We call them muscle spindle. Okay, muscle spindle is the receptor portion, and these are, to separate them from the rest of the muscle, we call these are extrafusal fibers. This one we call intrafusal fibers. Okay, I will not get into detail of it, but remember one thing, that if this is a receptor, it will have sensory nerve connected to it, right? So that sensation from this receptor can be carried to the spinal cord. Interestingly, even though this is a receptor, this have some motor fiber as well. Okay, they are the motor fibers coming to the muscle spindle are called gamma fibers. You see, these are the, when we say efferent, we means they are going out. When we say efferent, efferent are coming back to the muscle. Efferent are the fibers that is carrying sensation from the muscle to the spinal cord. Are you clear about efferent and efferent, those terms? Efferent is the signal carried from the nerve to the spinal cord or to the brain. We call them efferent or ascending. And the signal coming from the brain or spinal cord to the muscle, we call them efferent or descending or motor. Okay. Now look at this one. These two are actually motor fibers. These are the sensory fibers. These are the main components of receptor, right? So so remember, muscle spindle is the receptor located within the muscle. And they are, when a muscle is stretched, if you stretch a muscle, how the muscle respond? Muscle respond by producing contraction, right? So how the muscle will respond? So this stretching of the muscle need to be converted into an action potential by something, right? So who will do that? That is done by the muscle spindle. Muscle spindle is a type of receptor. Now look at here. So this is this is a very schematic drawing actually. So no muscle will be like this, but see, if this is the whole muscle, inside the muscle, this part is called this is the muscle spindle, which means this is the receptor part, right? So now, normally, do you remember I mentioned at the beginning that normally when the muscle is not stimulated, it is not flaccid. There is some activity still going on that maintain the muscle tone, right? Now look at this one. This muscle is at rest, this one, resting muscle. But you see, there is some signal coming from the muscle spindle. See, this one, this one, this one, which means they will not produce muscle contraction, but they will maintain a tone in the muscle. So that is tone, muscle tone is maintained by the muscle spindle, the impulse activity in the muscle spindle. That is something absolutely important. Now, when this muscle is now stretched, you stimulate the muscle by stretching it. So when you stretch the muscle, this muscle cannot determine it because muscle doesn't have a muscle. This is the receptor portion. The muscle spindle will detect the stretch in the muscle, right? So when the muscle is stretched, the muscle spindle within the muscle itself will also be stretched, right? So when they are stretched, now you see they are sending more signals, right? Why they are sending more signals? In response to stretch, right? Muscle is stretched. What will be the result when they send more signals? The muscle will produce contraction. So when a muscle contracts, what happens? The muscle's length become shorter, right? Any muscle. If I contract this one, the muscle become shorter, right? In response to contraction. So the now muscle become short. See, this was normal, this was stretched, this is shortened. Now, when the muscle is short, the stretch will disappear inside because when you stretch the muscle spindle was stretched, so it produced signal, right? Now, when the muscle is contracted, muscle becomes short. So now the stretch disappeared, right? On the muscle spindle, no stretch. In absence of stretch in the muscle, there will be no signal coming from muscle spindle because muscle spindle respond to stretch. Now, there is no stretch here. Muscle is now contracted, so they become small. So no stretching, which means no signal coming from the muscle spindle. Now, this part is a bit complicated. So we said there is a motor innervation to the muscle spindle as well, right? Now, if you somehow stimulate the motor part of the muscle spindle, what will happen? It will stretch the muscle spindle structure. And when you stretch the muscle spindle structure, there will be more signal coming from, and then it will cause much more stretching of the muscle. Okay, which means I will talk about this one actually when we talk about basal ganglia or cerebellum. I will mention that one at this point. Don't worry much about this part. Just know that muscle spindle has sensory supply that is carrying signal from the muscle, and they have motor supply as well, which means you can stimulate a muscle either by stimulating the muscle spindle's sensory supply, or you can stimulate the motor supply that are going directly into the muscle spindle. So if you stimulate the motor supply, the the muscle spindle will contract, right? When the muscle spindle will contract, their end of the muscle spindle will be stretched. That will eventually increase the signal intensity in the muscle fiber. But at these 2 points, just don't worry about this at this point. But remember, these three are absolutely important. This one, this little signal that is coming, why they are absolutely important? Because they are maintaining muscle tone. When you stretch a muscle, more signal will come. As a result, muscle will contract. When the muscle contracts, its length shortened and signal disappear from the muscle spindle. Are you clear about this much? Yeah, forget about gamma. Gamma, we will talk gamma later. Now, there are two types of receptors related to muscle. One is the muscle spindle. Other one is located in the tendon of the muscle. You see, this is the muscle spindle, right? This is the muscle fiber, right? Muscle fiber. And this one is the tendon of the muscle. Muscle's tendon also contain some receptors. They are called Golgi tendon organ. Okay, Golgi tendon organ. Now, the difference between these two are the signal that is transmitted by Golgi tendon organ, they are inhibitory signal. But the signal that are coming from the muscle tone, they are excitatory in nature. For an example, if you carry a weight, say normally your muscle is relaxed, right? But if you put a weight, if you hold a book on your hand, so your flexor muscles will contract, right? Because you are carrying a weight. Now you put another book there, so the weight increase, the tension in the muscle will increase, right? So you add the third book, the more tension will generate, right? You add the fourth one, more pressure will be on your muscle. Muscle will be much more stressed, more tension will develop in the muscle. But if you add the fifth one, depending on the strength of your muscle, eventually the stretch will go down, right? You cannot hold it anymore. So up to a certain point, the more you apply weight, the more will be force of contraction in the muscle. But at some point, when it goes beyond your capacity, your muscle at that point, without contracting stronger, it relaxes. So how it will relax? Because when you apply too much force, at that point, not only signal will go from the muscle spindle signal will stop, signal will now start going from the Golgi tendon organ. Now, when they stimulate, they inhibit the muscle. So the muscle will become relaxed. Okay. Now let me show you this one. This one is a good example. So this is the whole muscle, right? And this is the tendon here. Now, so this is the whole muscle here. This is the motor fiber coming to the muscle, the muscle's main motor fiber. It should be not stop there. It should stop here. This one should stop here, which is the extrafusal fiber. That will mainly cause the muscle contraction, right? And this yellow line here inside, this is the muscle spindle, the receptor part, right? Muscle spindle. So what is this nerve here? This is the sensory nerve coming from the receptor, right? So when you stretch this muscle, when you take a book on your hand, so this stretching of your muscle will be detected by whom? Muscle spindle. Muscle spindle will send sensory signal, because this is receptor, right? Sensory signal by type 1A fiber. Type 1A fiber is thick fiber, right? So which means it will transmit very quickly. It will come to the spinal cord, and you see, look at the end of this fiber. This come all the way here, and it directly synapse with the motor nerve that will go to the muscle and produce the contraction of muscle. So when you put the second book, the more signal will go, okay, and the muscle will contract even more. The third book you do, the more signal will go from here, and the more stronger will be the contraction. Now, or depending on how heavy the book is, say like fourth one is too heavy for all of us. When you put the fourth one, this one become now unbearable. Okay. At this point, a Golgi tendon organ, they will be stimulated because normally they don't do anything. They just keep quiet. But when it goes beyond your capacity to bear, then these Golgi tendon organ, the receptors located in the tendon, they become activated. And how do they send signal? They send signal to type 1B fiber coming from Golgi tendon. This one was faster, right? 1A. This one is not bad, 1B fiber, right? So this one, look at the destination of this. This one is dorsal root ganglia. It is coming here. Now, instead of coming directly to the motor nerve, it is stopping. It is synapsing with an interneuron, right? So this one stimulates this one interneuron, and this interneuron is an inhibitory interneuron. So what happened? This inhibitory interneuron, they will now produce inhibition at this junction. Okay, this is a synapse here again, right, between this interneuron and the motor neuron. When this one came, this stimulated the motor neuron, but this interneuron inhibited the motor neuron. So if it inhibit the motor neuron, this motor neuron was responsible for the muscle contraction, right? Now, if you inhibit this nerve, do you think the muscle will remain contracted? No. Muscle contraction will go away and muscle will be relaxed. So you see, so the two different response you get by stimulating two different type of receptors. Initially, when your muscle is stretched within limit, the more the stretch, the more will be the contraction produced by this one. More stretch will be carried by this one, and more contraction will be generated by this one, right? But when it goes beyond your capacity, this one will be stimulated. What is the difference between this one and this one? This one ended directly into the motor nerve and it is excitatory, but this one ended in an interneuron, which is inhibitory. That inhibitory interneuron inhibit this neuron. That's why this one is not sending any signal. So your muscle eventually become relaxed. So muscle tension now is less. Up to a certain limit, the more the stretched, the more will be the force of contraction. But beyond a limit, if you increase the stretch, the tension will go down. Why? How that one is mediated? That one is mediated through Golgi tendon organ stimulation, and that is carried by type 1B fiber. And sensory signal from the muscle spindle is carried by 1A fiber. And the motor neuron, they are composed of type 1 alpha fiber, right? You don't have to memorize them, but know that they will be, but this part is absolutely important. The fibers from muscle spindle synapse directly on the motor neuron, but the fibers from Golgi tendon organ synapse in the interneuron, which is inhibitory. Okay, that's why when you stimulate this pathway, this one will be inhibited. When you stimulate this pathway, this neuron will be stimulated. Is it tricky? Is it okay? It's okay, right? Yeah, as I said, those who have neuro background, for them it should be very simple, very straightforward. But we want to make it just for useful for everybody. That's why I talk about some very basic, very general things. So those who are very familiar with these things don't feel bad about it. So that's how it is. So so I think this is the last one. I don't have any more slides, so I will stop sharing. And